Hi everyone, this is Dr. Divya Shanthi. Welcome to NEET PG Core Revision series. These series are structured, focused and exam oriented so that you can recall faster and more confidently in your exams. In today's session, we are going to break down the anatomy of stomach into clear, high-yielding, exam-oriented concepts. So let's get started. The stomach is the most dilated, the stomach is the most dilated part of the entire GI system. That is a GI system when I say the GI tract, so the stomach is the most dilated part of the entire GI or the gastrointestinal tract. Now the stomach is between the esophagus, here this is the esophagus, and the duodenum. Here it intervenes between the duodenum as well as the esophagus, and it acts as a reservoir of food, and it converts the food into what we call as chyme. So it basically converts the food into chyme, and that is, chyme is basically of uniform consistency with the repeated churning. It converts the food, what we chew and swallow, it is converted to chyme in the stomach. And it also allows for the digestion of proteins. So proteins are also digested here to proteases as well as peptones with the help of the enzyme pepsin. So here the stomach also acts like an endocrine. It acts like an endocrine organ where it produces the hormone gastrin. It produces a hormone called as gastrin, which is produced by the antral cells, and this gastrin regulates the secretion of the hydrochloric acid, which is very essential for the digestion, hydrochloric acid and pepsin. In addition, there is an intrinsic factor, which is produced by the parietal cells of the stomach, and that is helpful. The intrinsic factor produced by the parietal cells is essential for the absorption of vitamin B12. So these are the very important functions of the stomach. So food in the stomach, it is retained there for about 3 to 4 hours normally. So usually it depends upon the type of food. So the protein, carbohydrate is very rapidly emptied by the stomach, whereas the protein rich food is slow and fatty food is retained for a longer time. So where is the stomach located? The location of the stomach is basically in the epigastric, left hypochondriac, and umbilical region. So in the 9 quadrants of the abdomen, it occupies the epigastric, the umbilical and the left hypochondriac region here. So this is the epigastric, this is the umbilical and the left hypochondriac region. So the capacity of the stomach is about 30 to 50 ml in the newborn, whereas in the adults it will increase to 1000 to 1500 ml on an average. So that is the capacity of the stomach. Now we have 3 shapes of the stomach. So stomach can be in 3 shapes in an individual. So it can be sthenic, sthenic shape. So sthenic is usually the normal type, sthenic or the normal. So the stomach, in sthenic what happens is the J-shaped stomach, So stomach will be kind of J shape. So the oblique limb, the longer limb, this is the longer limb of the J, will be slightly oblique. So this is the normal or the sthenic. In hyposthenic, hyposthenic is otherwise also known as the asthenic type. So here what happens, the J, if you see here, it is more vertical like this. Okay, so the J shaped is more vertical. So here you have to remember the individuals with hyposthenic or asthenic, they are likely to suffer because it is J shaped. So there is gastric stasis, the HCl secretions and all, they will be stasis, and that will result in what we call it as gastric ulcers. Okay, so hyposthenic, they are more prone for gastric ulcers. Then we have hypersthenic. Okay, so here the J becomes more oblique like this. So this shape or it is also known as the Steron type of stomach. Okay, and these people are more likely to suffer from duodenal ulcer. Because of the shape, the HCl can easily seep into the duodenum, where it can result in ulcer depending upon the amount of secretion and exposure for a longer time. So next, coming to the presenting parts of the stomach. Okay, so the stomach, if you see, will have two orifices. The cardiac orifice up here, the cardiac orifice, and the pyloric orifice. Two curvatures, the lesser and the greater curvature. This is the greater curvature. And it will have two surfaces. So what surface we see? This is the anterosuperior surface. And posteriorly we will have the posterior-inferior surface. So below we will have the posterior-inferior surface. And it is divided into three parts mainly, the fundus. So this is the fundus part. This is the body, and the pylorus. This is the pylorus. So the pylorus will consist of two parts, the pyloric antrum. So this portion we call it as the pyloric antrum part here, and the pyloric canal. So together it will be about 10 centimeters. So the pyloric antrum part will be about 7.5 and this will be about 2.5 centimeters. So these are the presenting parts of the stomach. So when we see the cardiac orifice, so cardiac orifice will be about 2.5 centimeters to the left of the median plane. It is more towards the left, okay, left of the median plane. And the pyloric orifice here, okay, the pyloric orifice will be demarcated by a constriction, okay, and we can identify the pyloric orifice in the living because there by the identification of the prepyloric vein of Mayo. Prepyloric vein of Mayo. So this prepyloric vein of Mayo will be in relation to the pyloric orifice. So we can identify the pyloric orifice during surgery and all. We identify the pyloric orifice with the identification of prepyloric vein of Mayo. So this pyloric end is situated about 1.25 centimeters to the right of the median plane, okay, so the midline. So it will be at the lower border of L1 vertebrae, whereas this one we will be seeing cardiac orifice at about T11, okay, sorry, T11 vertebrae level. So let's move on to some of the important features what we see here. So here you have to know one thing is the Traube space. So what is this Traube space? So Traube space is basically an area which overlies, okay, which overlies the fundus of the stomach, okay, in this part. The fundus of the stomach, it overlies that area. So this we call it as the Traube space. Traube space. Now this Traube space is normally, when we percuss, it is tympanic. Tympanic note, okay, you get a tympanic note on percussion. So this Traube space is bounded. So if you see here, above, it will be bounded by the lower border of lung, and below here we have the costal margin. The left costal margin is there. Then right side here, on the right side we will see the liver, okay, the left lobe of the liver on the right side, okay. So we will see the left lobe of liver on the right side, and left side here, okay, we will have the spleen. So it is bounded by the lung, above on the right side by the liver, and on the left side by the spleen, and below the costal margin. Now what is the importance of this space? Now this space, I told you, normally it is tympanic in on percussion, tympanic note you get. But in the pathology of this, okay, so it may be the enlargement of the liver, hepatomegaly or splenomegaly or pleural effusion, okay, HEBA. So in that what happens, this space is obliterated, and depending upon which organ, if it is like we have the liver enlargement, hepatomegaly or splenomegaly, we get a dull note on percussion, right? So that is the importance of this Traube space. So when we take a plain X-ray of the abdominal region, okay, this is how we see, okay. So this part here you can see it is the fundus. So fundus usually it is air filled, okay. So it is filled with air even when the stomach is empty. So this appears as the fundic shadow. We call it as the fundic shadow in an X-ray. So this is a normal appearance of the stomach. That is how we see it, okay. So sometimes if this fundus is filled with gas like more, so what can happen is it can cause a little bit of cardiac distress. It is when it is distended too much, because it will be extending below the left cupola of the diaphragm here. This part is the diaphragm, left cupola of the diaphragm, and it will be extending up to the left fifth intercostal space where we have the apex beat, okay, apex beat in relation. So up to there it will be extending. So when it is over distended with gas, it can cause cardiac distress. So that is one thing you need to remember. This picture is basically of the barium meal. Okay, so we can see, so because it is a soft tissue, we cannot see the stomach in a X-ray, okay, in a plain X-ray we cannot see, so we need to take a contrast X-ray, and usually to see the stomach and the upper GI part, okay, for the esophagus we use a barium swallow, for the stomach and the upper part of the intestines we use a barium meal. So this is a barium meal X-ray here you can see, so this is the stomach, you can see the pyloric end here, this is the duodenal cap which we see. So this is how we recognize the stomach, and here you can see the fundus here, okay, which is this portion is the fundus. So I already told you the subdivisions of the stomach. So this is the interior of the stomach. So interior of the stomach, when we see, okay, we see the 4 G's. Okay, so the stomach is thrown into a lot of mucosal folds. These mucosal folds we call it as the gastric folds. Okay, then we have the within this mucosa, okay, beneath that in the submucosa and the mucosa we have the gastric glands. Okay, gastric glands are present, which may not be visible in the gross specimen, and if we see very closely there will be some pits, so where these gastric glands will appear, small pit like appearance, that is the gastric pits. And along the lesser curvature of the stomach, okay, so along the lesser curvature what happens is the folds are less, okay, that is that part we call it as the gastric canal. Okay, so this gastric canal, it is also called as the canal of Magen-Tresek. So here the liquids flow very freely along this surface, and along this area of the gastric canal, and this gastric canal area is more prone for gastric ulcers. So this is about the interior, and when we see here the interior, here we can see this is the fundus. Okay, so this portion is the fundus, this is the body, and this portion from here to here will be the pylorus part, which is subdivided into pyloric antrum. Pyloric antrum, this is the pyloric canal, okay, and this portion here where it is narrowed, we call it as the pylorus, that is the pyloric orifice part. So length of the entire pyloric part, this of the stomach, it is about 10 centimeters. So pyloric antrum will be about 7.5 and pyloric canal about 2.5 centimeters. So that is about the interior features of the stomach. So at the pylorus, it is the anatomical sphincter here. Okay, at the pylorus we have the anatomical sphincter. Here the circular layer of the muscles, okay, they are more thickened there. So that is what we see at that part. So here we can see, okay, so I had earlier mentioned that there is the prepyloric vein of Mayo, okay, so which is in relation to the near the pyloric, it will be in relation near the pyloric orifice. So seeing that, we can identify the, not this one, it will be out here. So with that we can identify the pyloric orifice. Okay, so there is a clinical condition in association with the pylorus. Okay, so it is called as hypertrophic pyloric stenosis. So this hypertrophic pyloric stenosis is basically a congenital condition which results in neuromuscular incoordination at the pyloric orifice. So this is mainly because of the thickening. So if you can see here, there is the thickening of the circular layer of smooth muscles. So because of that, it results in narrowing. So in the postnatal life, okay, the newborn usually presents with vomiting. So usually about 10 to 15 days or within a month of after birth in the postnatal life. So this is relieved by a surgery which we call it as the Ramsted's operation, where the circular hypertrophied muscles, it is released, okay, by making an incision along the circular layer of muscles, and the obstruction is released there. Then coming to the relations, okay, coming to the relations of the stomach. So there are certain important structures lying in relation to the stomach, and we need to know them. So along the lesser curvature here, okay, we have, it gives attachment. So if you see here, the lesser curvature gives attachment to what we call it as the lesser, two layers of the lesser omentum. So this is the lesser omentum. So this lesser omentum, which consists of the anastomosis of the right and left gastric arteries. Then along the greater curvature, okay, along the greater curvature we have the greater omentum here, okay, here we can see, and it basically consists of the right and left gastroepiploic artery. Anastomosis is seen within this. So when we see the peritoneal relations of the stomach, okay, so along the lesser curvature, as I said, we have the lesser omentum, and this is the greater omentum. So at the cardiac end, okay, at the cardiac end of the stomach, here we can see the gastrophrenic, okay, so that is between the stomach and the diaphragm, we see the gastrophrenic ligament. Then opposite the fundus, here we see the gastrosplenic ligament. Okay, so here we see, and rest of the greater curvature, we see the anterior two layers of the greater omentum. So, which consists of the right and left gastroepiploic arteries, anastomosis is present there. Then the entire anterosuperior surface, here if you see, it is covered by the peritoneum. Okay, it is covered by the peritoneum of the greater sac, and on the right part, okay, that is extending from the cardiac orifice up to the pyloric antrum, it will come in contact with the left lobe. Okay, it is related to the left lobe of the liver as well as to the quadrate lobe of the liver. Quadrate lobe of liver. Okay, so that is on the right side, and in the upper part, okay, so here it will be related. So the anterosuperior surface will be related from the cardiac orifice up to the pyloric orifice on the right side to the lobes, left lobe as well as the quadrate lobe of the liver. Whereas on to the upper and left part here, okay, that is the fundus and the part of the body, it is related to the diaphragm. Okay, here it is related to the diaphragm, and sometimes small gastric impression, that is spleen, also can be seen here. Okay, and outside, okay, here it will be outside the diaphragm part, it is related to the left pleura and base of the left lung, as well as pericardium and heart. And this portion here, okay, in the intermediate part, it comes in contact with the anterior abdominal wall, and that part we call it as the gastric triangle. So, and when the stomach is empty, in this part we also see the transverse colon in the lower part here. We will see the transverse colon across the lower part when the stomach is empty. So, these are the relations which we see on the anterosuperior part. So, the posterior-inferior part, okay, so here we also see along the curvatures, okay, so earlier already I mentioned to you the ligaments here. So, we can see this is the lesser curvature. Along the lesser curvature, we have the lesser omentum. Okay, so here the right margin, this is where the epiploic foramen will be there. So, you can see that here, and here along the greater curvature in the upper part, this is the gastrophrenic ligament. Here we have the gastrosplenic between the stomach and the spleen. This is the gastrosplenic. And here we have the great omen. So you can see this is the transverse colon. So when the stomach is empty, we can see the transverse colon in the lower part of the stomach. So this is the ligaments of the stomach, okay, the peritoneal ligaments which we can see in relation to the stomach. Only a small part here, okay, near where the esophagus joins the stomach, only that small part is not covered by the peritoneum there. So it's the same thing what I already told you. So we have the left lobe of the liver here, and here we have the quadrate lobe in relation. Now this portion in the lower part, what we can see here, this we call it as the gastric triangle. Okay, so this gastric triangle is the area of the stomach which is in direct contact with the anterior abdominal wall. Now why is this gastric triangle important to know? Okay, so this gastric triangle is the site where we do the gastrostomy. Okay, so feeding gastrostomy tube, because the moment we put a nick in the anterior abdominal wall, it directly reaches to the stomach. There is no intervening structures between them except for the layers of the anterior abdominal wall. So in case of esophageal cancer or throat-pharyngeal cancer, where the patient is not able to swallow, okay, there is some difficulty in swallowing, or in those cases where we cannot put a Ryle's tube, we do a feeding gastrostomy, okay, and that is done in this gastric triangle area. So this gastric triangle area is bounded, if you see, on the right side by the lower border of the liver, on the left side by the left costal margin, okay, so the left border of the liver, the costal margin here, and below it is the transverse colon. So transverse colon will be running here. So the liver, the costal margin and the transverse colon will be forming the boundaries. Okay, so this is the region which will be in direct contact with the anterior abdominal wall. Gastric, it's called gastric triangle. So two areas of stomach are there. One is the �𝗏𝗏 area, other one is the gastric triangle. So this is how a feeding gastrostomy tube is put. Okay, so this is the anterior abdominal wall layers and a tube is put. So you can see it directly opens into the stomach. This is the feeding. So usually this is done in complete esophageal obstruction, where the patient will be unable to swallow. Now when we come to the posterior relations, okay, for the posterior inferior surface of the stomach, those structures which are present, they are known as the stomach bed structures. Okay, so the stomach bed. So here the posterior inferior surface, again it is covered by the peritoneum, okay, peritoneum of the lesser sac, except the bare area, that is the small area which I told you near the cardiac end of the stomach, where it is not covered by the peritoneum. So these structures now which are in relation to the posterior inferior surface, we call them as the stomach bed structures. So here, what are the structures? From above downwards, when we see what structures form the stomach bed. So first we have the left crus of the diaphragm, left crus of diaphragm. Then as we come down, we have the left adrenal gland, and after that the left kidney, anterior surface of the left kidney. And then we have the here after kidney, you can see the kidney here, and after that what you can see here, that is the splenic artery, the splenic artery. Then we see the anterior surface of the pancreas and the transverse mesocolon. So here you can see this portion is the transverse mesocolon. And after that will be the anterior layer of transverse mesocolon, and sometimes we can see the left colic flexure here. So this is the left colic flexure. So these structures from above downwards, the left crus of the diaphragm, the left adrenal gland, then the anterior surface of the left kidney, then as we come down the tortuous splenic artery, the anterior surface of the pancreas. As we come down still, we have the transverse mesocolon and sometimes the left colic flexure, which forms the posterior inferior relations and form the stomach bed. Okay, so this is when we see the outer line, just to remember, we can see. So this is the diaphragm. You can see the adrenal gland here, the kidney, left kidney, the splenic artery here. This is the splenic artery. This is pancreas. Here we have the transverse mesocolon. Okay, so the outline of stomach is there. So you can understand how the structures are in relation. And sometimes here small pore. This is the left colic flexure. So when you remember from above downwards in the order how anatomically they are present in our body, it is easy to remember. So these structures, they form the stomach bed. So it's a very important MCQ question which you have to know. So interior I already explained to you. So we have so you can see here there are a lot of mucosal folds. So this mucosa folds, we call it as the gastric folds. Then we have Here you can see the small openings, those are the gastric pits into which the gastric glands will open. And this is the gastric canal. So you can see here that the mucosal folds are less. Okay, so usually the liquids, they flow easily, freely along the lesser curvature. So that is why any irritant fluids, okay, like alcohol or high carbonated drinks and all, they can cause ulcers along the lesser curvature. This is just to have an overview of how the muscles are arranged. So in the stomach, okay, the muscles are arranged in 3 layers. Okay, we have the circular, the longitudinal as well as the oblique muscles. So why the muscles are arranged in 3 layers is basically so that the food is nicely churned within the stomach. It is broken down and turned into chyme. Okay, so that is what we see here. This is the different ways. So circular, oblique, so circular layer, we have the oblique as well as the longitudinal layers of muscles which are arranged there. So the blood supply of the stomach is mainly by the right and left gastric and the right and left gastroepiploic arteries. The left gastric artery is mainly the branch from the celiac trunk, okay, it's branched from the celiac trunk, whereas right gastric artery is a branch from the common hepatic, which is a branch of celiac trunk, okay. So they run through the lesser omentum and along the lesser curvature, the anastomose, and then they give the artery, they form the arterial arcade around that, giving the subserosal intramuscular as well as the submucosal plexus. And along the greater curvature, we see the left gastroepiploic and the right gastroepiploic. So the left gastroepiploic is a branch of the splenic artery and splenic artery is a branch of the celiac trunk, whereas right gastroepiploic, it is the branch of the gastroduodenal artery which comes from the hepatic artery. Sometimes from the splenic artery we also have posterior gastric artery which will supply, and there are few fundal branches which supply the fundus here. So here one thing which you need to remember is the submucosal plexus, okay, submucosal plexus which are present, because from the submucosal plexus the long mucosal arteries will begin from where they will be supplying the mucosa of the stomach. Okay, but these submucosal plexus, they are mainly absent along the lesser curvature, okay, lesser curvature. So because of which what happens, the long slender mucosal vessels, they arise straight from the arteries itself, that is from the left gastric and the right gastric, okay, and they will be piercing the musculature obliquely. So what happens is, if there is occlusion of these elongated arteries, right, mucosal vessels, it can produce ischemia along the lesser curvature. Okay, so any occlusion or obstruction there can produce ischemia, and that is why usually, okay, peptic ulcers are more common, because for any ulcers to heal there should be a good supply of blood, and that is not there. It is compromised along the lesser curvature, and so we see more of the peptic ulcers in that region. So the venous drainage of the stomach, when we see, it corresponds to the arteries, okay, and they drain directly or indirectly into the portal vein. So the right and left gastric veins, okay, so the right and left gastric veins, they drain into the trunk. So you can see here they are draining into the trunk of the portal vein. The short gastric, okay, here. These are the short gastric corresponding to the short gastric arteries. So this short gastric and the left gastroepiploic, it will drain into the splenic vein. So the short gastric arteries and the left gastroepiploic artery will be draining into the splenic vein. So this is the splenic vein, which is a formative vein of portal vein, okay. and we have the right gastroepiploic here. This is the right gastroepiploic, and this will be draining into the superior mesenteric vein. So we know that superior mesenteric and the splenic vein together will be forming the portal vein. So that is about the venous drainage here. And the lymphatic drainage, coming to the lymphatic drainage, so we divide the stomach into 4 areas. Okay, so the right 2/3 and the left 1/3. So here we have the 2/3 area, 2/3 into 1/3 left, 1/3 we divide by a line. Okay, imaginary plane. And again the right 2/3 we divided into upper 2/3 and lower 1/3, and the left 1/3 we divide into upper 1/3 and the lower 2/3. So here when we see the lymphatics, they drain into different regions here. Okay, so usually from the upper 2/3. Okay, so from the upper 2/3. So this is the upper 2/3. Okay, upper 2/3. This is the lower 1/3 on the right side, whereas here upper 1/3 and we have the lower 2/3. So from the upper 2/3 of the stomach here now, it drains into the left gastric. Okay, so here it drains into the left gastric lymph nodes. And from the lower 1/3 of the right part, it drains into the right gastroepiploic group of lymph nodes. This is the right gastroepiploic group of lymph nodes. Then from the pyloric part, okay, from the pyloric part, the lymph drains into 3 regions here. So it drains into the hepatic group. Okay, so it drains into the hepatic group at the porta hepatis, and it drains into the pyloric group here just below the pyloric orifice, and it also drains into the left gastric lymph nodes. Okay, so hepatic group, pyloric group and the left gastric lymph nodes. So that is in the lower part. And then here we also see in the upper 1/3 it goes to the pancreatico-splenic group of lymph nodes. Okay, so this is the pancreatico-splenic group of lymph nodes. So that is the main lymphatic drainage of the stomach. The lymphatics is very important because in gastric carcinoma, the spread of cancer is through these lymphatics, and there we will see a very important sign. Okay, so in the left supraclavicular region, okay, where at the junction of the internal jugular with the subclavian, there in that region where the thoracic duct also opens, there we see the left supraclavicular lymph node enlargement, and which we call it as the Virchow's node. Okay, so this is important, and this is mainly we see it in the gastric carcinoma, because of the lymphatic spread. Then coming to the nerve supply of the stomach is supplied by both sympathetic as well as parasympathetic. Okay, sympathetic. So sympathetic is mainly by the celiac plexus. Okay, sympathetic is by the celiac plexus, and parasympathetic is by the vagus nerves. So here the parasympathetic supply is slightly important, which you need to pay attention. So the parasympathetic supply is derived from both the vagus, the right and the left vagus. Okay, so they form the anterior and posterior trunks. So in the form of anterior and posterior. So anterior vagal trunk. Okay, so when we see the anterior and the posterior, we see, so the anterior vagal trunk basically consists of the one or two bundles which are formed by these. So you have to remember, when we say anterior vagal trunk, because of the rotation of the stomach during the development, the anterior vagal trunk is nothing but the left vagus and the posterior vagal trunk is the right vagus, because the stomach rotates there. So the right becomes posterior and the left becomes anterior. Okay. So the anterior vagus will be supplying, okay, so anterior, which is nothing but the left vagus, vagal trunk, will be supplying the anterosuperior surface and posterior, okay, posterior vagal trunk on the right vagus supplies the posterior inferior surface of the stomach. So here this vagal trunk gives branches which supply specifically to the stomach, the gastric branches, which we call it as the nerve of 𝗲𝗪𝗔𝗟. Okay, nerves of 𝗲𝗪𝗔𝗟. So they run along the lesser curvature, okay, within the lesser, both anterior or posterior, they run along the lesser curvature in close relation to the lesser curvature, and then they will be supplying the stomach. Okay, so that is about the anterior and the posterior vagal trunk. So why this is important is, okay, in chronic cases of gastric ulcers, okay, so gastric ulcers are very common and mainly along the lesser curvature. So the patient may present with pain, okay, with belching, excessive gastritis, okay. Sometimes if there is bleeding, it can also result in melena, that is passage of blood in the stools, we call it as melena, distension of the abdomen, okay, there may be weight loss, vomiting. All these things are some of the symptoms of gastric ulcers, okay. So in gastric ulcers, so to heal the gastric ulcers, sometimes we perform the vagotomy surgery. So there are three types of vagotomy surgeries, okay. There is truncal, that is selective vagotomy, truncal vagotomy, selective vagotomy and highly selective vagotomy, okay. So three kinds of surgeries are there. So when we talk about truncal vagotomy, okay, so truncal vagotomy, basically the main trunk itself, okay, depending upon whether anterior or posterior. In truncal vagotomy, what we do, okay, we denervate the main trunk itself, okay. So the main trunk itself is cut there in truncal vagotomy, but this can cause gastric stasis, okay, because the nerve supply, the main nerve supply is entirely, the nerve supply is gone, and because of which the gastric emptying time is delayed, okay, and gastric stasis can happen in truncal vagotomy. So main trunk we section here. So the main drawback of the surgery is the stomach becomes atonic, okay, there is no tone, and so because of that, because the entire stomach becomes atonic, now how should the gastric contents pass? So for that sake, pyloroplasty is done, okay, either pyloroplasty is done, so the entire that pyloric splinter part is removed, or gastrojejunostomy is done, where the stomach is directly connected to the jejunum, okay, so it bypasses. So because this can cause, because of all these complications, okay, it can cause post-vagotomy diarrhea, okay, it can result in post-vagotomy diarrhea. Now why post-vagotomy diarrhea here? Because of the damage to both hepatic and celiac plexus, because the trunk itself, the anterior and the posterior vagal trunk, they themselves form the plexus around there, okay, the hepatic plexus as well as the celiac plexus. Now because all of this is affected, it results in post-vagotomy diarrhea. So the next surgery what we do is the selective vagotomy, okay. So the next is selective. So this, since it has so much of complications, we do not prefer the truncal. Instead, we do this selective vagotomy. Okay, so the next type is selective vagotomy. Now, this selective vagotomy sections the nerves of lateral jet. Okay, so nerves of lateral jet, they supply the stomach mainly. So here in selective vagotomy, we section the nerves of lateral jet of both anterior and posterior vagal trunk. But again, this, though we are only sectioning the nerve supplying the stomach, still it has complications. Why? Because it reduces the mobility of pyloric antrum. It decreases pyloric antrum mobility, and again that results in decreased gastric emptying. So the third type of surgery, that is, we do highly selective vagotomy. So in highly selective vagotomy is the operation of choice. Okay, so nowadays only in case vagotomy is done, this is the surgery preferred for the gastric ulcers. So in this type, okay, that is selective vagotomy, what do? Here we denervate or we section only those branches, okay, which are supplying the acid bearing area. Okay, now see, this vagotomy surgery is done for gastric ulcers, and gastric ulcers are mainly due to increased HCl, right? So vagotomy is mainly performed to reduce the production of the hydrochloric acid from the parietal cells. So that is why we do this surgery. So now here we ligate only those, or we section, okay, we denervate or we section only those nerves of lateral jet which are supplying the acid bearing, producing part. Okay, so the parietal cells where they are there and where this acid secretion is more, only those areas are nerves supplying that area is sectioned here. So both. So this is the, so this will not cause all the other complications which we saw in the truncal vagotomy or selective vagotomy. So let's now solve some of the image based MCQs. So endoscopic, this is the endoscopic picture. So structure, what structure is seen here, okay, on the lesser curvature. So this notch is basically the incisura angularis, okay, incisura angularis. The second question, CT showing posterior relations of stomach, structure forming the stomach bed, okay. So among the structures here, so the liver doesn't form, pancreas, yes, colon diaphragm, the left diaphragm, okay, the left part. So the more likely we can choose is the pancreas here, and that is what actually is pointed here. Okay, so pancreas should be the right answer. Then artery identified, okay, so here the question mark is over here for this question. So the artery identified here, that along here in the upper part, it is the left 𝗕𝗵𝗄𝗆 artery. Ligament between the stomach and the spleen, okay, ligament between stomach and the spleen is the gastrosplenic, right? So gastrosplenic is the C is the right answer. So that's a wrap on today's session of stomach. So be consistent with this series, as consistency is the key to success. I will see you in the next session.